Again, the incidence of these different types of tumors put in the form of a pie chart. We won't dwell on that. Okay, now, clinically, originally carcinoids were thought to be practically benign because they lasted so long and didn't seem to do anything. But as we notice now, they are not quite that benign, and some are more malignant. And actually, as many as half the cases have spread already by the time they're first diagnosed. So in light of this, we're becoming more aggressive in our management, in our treatment. Also, we've got more things we can do in treatment now. And here, just showing the effect of the location from which the tumor arises. You see the rectal carcinoids are mostly localized. They haven't really spread when they're first diagnosed. 92% have not extended. The lung carcinoids, on the other hand, about half of them are local, and the others have at least regional spread, if not more distant. And then those arising in the intestine, in the small bowel, a little bit less than 1/3 are localized, and the rest have lymph node or even more distant metastases. So it's very important to know where the tumor came from. That has a big bearing on what's going to happen. And you see that the diagnosis is often very delayed, as many of you know from your own experience. But again, expressing relationship to all malignancies, only 2% of the gastroenteropancreatic tumors or carcinoid neuroendocrine tumors are malignant. That is, only 2% of all malignancies are made up of those cells. They may be functioning, they may not. Microscopically, unless special staining and special attention is given, all neuroendocrine tumors look the same. And originally, there was a tendency for the pathologist to report on a biopsy carcinoid, no matter what kind of a net it was, because they didn't look any different. We know better now. But it's very important to be certain that the pathologist stipulates the details. Now, just a brief word on a very rare occurrence of familial or inherited neuroendocrine tumors. They're very rare. They comprise, at the best, 4% of all carcinoid nets. The commonest of that group would be MEN1, or multiple endocrine neoplasia. And this is inherited and passed down as a so-called autosomal dominant tumor. That is one in which 50% of the offspring will develop this. We can do a blood test to show the chromosomal abnormality and hence determine who is at risk in the family for getting this. It's expensive and not always covered by insurance, and it's not recommended as a randomized type of test, but only when there's a reasonable clinical suspicion that this is a familial situation we're dealing with. Similar familial transmission of neuroendocrine tumor, usually in the pancreas, is so-called von Hippel-Lindau syndrome. Or again, we can do a test for the chromosomal disturbance. Then even rarer is neurofibromatosis type 1 and another condition called tuberous sclerosis. More recently, we've become interested in familial carcinoid. Apparently, there are families in whom this tendency to develop carcinoids is transmitted, and the genetic abnormality involved is not yet well characterized. There are studies going on down at the National Cancer Institute at the NIH right now in attempting to unscramble what the aberration in the chromosome is that makes this familial carcinoid. It's also being studied elsewhere, and it doesn't seem to me to be quite that rare, as I've seen a good half dozen such cases. Now, on a clinical basis, what is carcinoid syndrome? There seems to be a lot of confusion between what's the difference between carcinoid and carcinoid syndrome. Carcinoid, of course, is the tumor, and carcinoid syndrome is a constellation of features which encompass not only having the tumor and having it spread usually, but also having it produce lots of hormonal substances that is causing symptoms. The major symptoms are flushing, episodic intense redness and heat in the face, diarrhea, and you don't need to have both features. You can have one or the other or both. In the neglected cases, the patients will get pellagra because of a deficiency of niacin, and pellagra is characterized by diarrhea, skin rash, and also mental changes. And of course, on top of the diarrhea of carcinoid syndrome, you don't need to have pellagra too. This we don't see so much in this country because our foods are fortified with niacin. But in patients who are malnourished or who don't eat well and have carcinoid syndrome, we can have it. And therefore, it's very simple to just give everybody a little supplement of niacin. And that is often my custom. We may get asthma-like symptoms, bronchospasm, that are indistinguishable from ordinary asthma. We may have cardiac features, certain types of valvular disturbances that result from serotonin-induced scarring on the valves, particularly the right side of the heart, and so we can have a form of right-sided heart failure, and on rare occasions that may be the presenting symptom. We're seeing less of that nowadays because of the advent of the use of octreotide, you know, as sandostatin, which lowers blood serotonin usually, and so we don't see as much of the heart features. We can have other types of heart symptoms or heart disease from carcinoid. Tumors may spread to the heart or to the pericardium lining about the heart, or simply the hormones produced overstimulate the heart and the heart gets exhausted and we get a form of high output heart failure which doesn't have any anatomic abnormalities to be demonstrated. And then finally, we usually have an enlarged liver due to spread of the tumor to the liver, but we don't have to. You can, in certain instances, you can have the carcinoid syndrome from a primary tumor, like in the ovary, if it makes lots of serotonin and other products and drains into the systemic system, not into the liver, like those arising in the gut do, then you can have the carcinoid syndrome without metastases. Extremely rare, but also very important because a complete cure can be produced by removing that tumor if you think about it and find it. Then we have a number of minor features that go along with carcinoid syndrome. 1/4 of patients will have peptic ulcers. We may have very low blood serum albumin. We will have wasting, atrophy of muscles. We'll have joint pains. We will have pain in the muscles and fibrosis, scarring. And apparently serotonin has the ability to stimulate scar formation. And so some of these complications from scar formation may be the presenting feature. For example, retroperitoneal fibrosis, that's scarring that forms deep in the back of the abdomen and can engulf or surround the ureters that carry the urine from the kidneys down to the bladder, and so constrict them and cause damage to the kidneys. That may be the first presenting symptom. It's rare, but it is noted. In certain rare cases, we get a particular type of pigmented edema, swelling in the feet. And then finally, hyperglycemia. Serotonin interferes with glucose, carbohydrate metabolism, and so people who have a diabetic tendency will get worse when they have carcinoid. Or those who don't have diabetes will get an increase in their blood sugar. And this is something worthy of keeping in mind. Okay, so how is carcinoid diagnosed? Well, the first thing is, and most important, it has to be suspected. If it's not considered, then you don't even look for it. Again, if you don't suspect it, you can't detect it. And that's why the zebra is the icon for carcinoid. Doctors are taught when they hear hoofbeats, think of common things. When they see symptoms that are common, heart failure or diarrhea, they think of what the common diseases are that cause it. The zebra is uncommon. They have to think now and to include the possibility of a zebra. In other words, the carcinoid, something uncommon. Okay, but once suspected, you can do the markers, the different chemical tests, and they will often help in establishing the diagnosis. Then you can do imaging, that is x-rays or other scans, other types of things that will show a tumor. In particular, the Octrio scan. That's a scan in which a radioactive isotope is attached to a substance, a derivative of a chemical called somatostatin, and this is attracted to most of these tumors, about 80 or 85%, and so it'll light up on the scan, and that helps confirm what the diagnosis is, and it also helps to tell you where it is, and sometimes show you spots that you didn't think of that might have it. And then we can do biopsies. Of course, to get a piece of tissue confirms the diagnosis, and it's almost mandatory before treatment that a tissue diagnosis be established, because we don't want to get into treating the wrong thing in error for years or for a long time. There are many different markers that can be done. The main ones, and the classic, is the 24-hour urine 5-HIAA, stands for 5-hydroxyindolacetic acid. It's the waste product of serotonin, and it's excreted in the urine, and it requires a 24-hour urine collection and avoidance of foods that are highly rich in serotonin, so that we don't artificially pump up this 5-HIAA. But we can't rely on that alone. It'll miss about 1/3 of the cases. So I like to have blood serum serotonin. It fluctuates considerably, but it's a pretty sensitive indicator. It has to be fasting. If you eat, every time you eat, the blood serotonin goes up temporarily. And then we also have chromogranin A, which is another substance produced by most, not all, but most of these tumors, but it's not specific for carcinoid. All of the NETs, except for insulinomas, will produce an increased amount of chromogranin A. And it doesn't depend upon whether it's a functioning tumor. You don't have to have the carcinoid syndrome for an elevated chromogranin A. Now, we also have some other markers that I haven't listed here that are coming into greater use and are very sensitive. Pancreastatin is one, neurokinin A is another, and something called substance P is yet another one. And these are all available. Okay, what is the natural course of carcinoid? Well, it's usually slow. There are exceptions. About 20% of those arising in the small bowel will spread more distally, and the likelihood of that depends upon the size of the tumor to begin with. The bigger the tumor is at the time it's first diagnosed, the greater the chances are that it will or has already spread. And if the tumor is greater than 2 centimeters in diameter, that means just a wee bit less than an inch in size, there's a better than 50-50, there's a greater than 60% chance that it will spread or has. So this is very important, and it also emphasizes the benefits of early diagnosis, increased awareness to early diagnosis. Get them while they're small, and you can cure them often. At any rate, about 40% or less of cases with small bowel carcinoid that has spread will actually show the carcinoid syndrome. So it's not the commonest occurrence. Now, this is very important, and sometimes we have to be our own advocate. I'm talking about the patient. At a recent meeting of NANETS, the North American Neuroendocrine Tumor Society, this group of specialists in the United States who represent most of the doctors who work with this type of disease, we determined what we thought was the minimum information the pathologist should provide to the doctor on a biopsy to tell us best what we're dealing with and what we might do. And so we want to know where the biopsy came from. It's not good for them to just say carcinoid. I want them to say that this is a piece of tumor that was taken from the liver or from the lung or from wherever, and tell us if it's the primary or if it's a metastasis. Graded, that is, well differentiated, moderate differentiated, poorly differentiated, or also listed as grade 1, 2, or 3. Give us a mitotic index. That means the incidence of mitotic figures or mitosis. Mitosis is the process whereby cells undergo division and replicate. In other words, it's the multiplication of cells or the rate at which they grow. And so we want to know how many of these mitotic figures are seen in 10 high power magnification fields under the microscope. And this helps to tell us about the rate of growth and aggressiveness of the tumor. So does the proliferation index, which is measured by staining for Ki-67, that's a protein substance, or MIB1, which is a related substance, in the nucleus of the cell that shows up when the cell is about to divide or is actually already multiplying. And so we want to count what % of cells have this positive stain. That also tells us about the aggressiveness of the tumor. And then finally, they can give us the diagnosis. Are we dealing with a gastrinoma? And to do that, we have to, it may look the same as a carcinoid, but it will stain for gastrin, for example. And then if we are uncertain that it's a neuroendocrine tumor, they always have to stain for chromogranin A and synaptophysin. These are other materials which are common to all of these tumors. And finally, we want a TNM staging. That means staging of the size of the tumor, that's what the T stands for, and other features of it, its extent, staging of whether there's lymph node, that's the N node involvement, and staging if there a statement if there's a distant metastases, that's an M. So they may say T2N1 M3 or something like that, and that way we hope to make a standardized reporting system throughout the country, and that way we can all be on the same page when we're dealing with these tumors. This is new, this insistence, but it's going to take hold. Now, the prognosis. Again, as I've been saying, it depends upon where the tumor starts. The appendiceal carcinoids are almost all benign. There's an exception, maybe 1%, and then those are usually bigger and have extended a bit. Rectum is usually pretty benign. Next, the lung, and then the gut, and the most malignant in general are those tumors arising in the pancreas. Again, as I said before, the size of the primary tumor is important. The depth of invasion of the supporting tissue, that is, did the tumor arise just in the lining of the intestine, or did it actually grow into the wall, into the muscular part of the wall of the intestine, or even further? This is important to determine its behavior. There are other features in histology, the pattern, which are important, and I won't go into those. Those patients with carcinoid syndrome have a worse outlook than those without. Unless the syndrome is controlled with octreotide, then the outlook is equal to the non-functioning tumors. But as I have been emphasizing, there is a wide variation, and prediction is difficult. Okay, finally, treatment issues. I've divided treatment into 3 groups: supportive, surgical, and antiproliferative. And that's purely my arbitrary categorization, and often these modality or these groups are all employed at the same time. For medical supportive things, we have all the antidiarrheal drugs when that's a problem, and you see them written. I won't dwell on them all, or the mechanisms, and questions about these can be asked during the question-answer period. Nutritional factors are important. Diet is very important, and the supplement of niacin. MCT means medium-chain triglycerides. This is a form of fat or oil that is easily absorbed, and if malnutrition is a factor, MCT may help. And then blood-forming elements, iron, that's the hematinics, and other things like B12. If necessary, supplementation of electrolytes if loss of these things is occurring in diarrhea. Anti-ulcer medicine, because as I told you, ulcers are very common in carcinoid. The question of anti-fibrosis agents is a moot one because it's not been proven, but I do feel that fish oil, omega-3, has been helpful, and there are some animal studies to support that, so I encourage that use. Now, surgical approaches. There are a whole panorama of things that can be done surgically, starting, of course, with a biopsy for the diagnosis, which I said was essential. But then we can cure tumors by their complete resection when that's possible, but we can help even when it's not, by debulking. If there's lots of tumor tissue, reducing the amount to a significant degree can prolong survival and certainly add to comfort. We may be required sometimes to do operation just to control bleeding from some source, or relieve intestinal obstruction, if that's the problem, or if there's poor blood flow to the tumors in the intestine, we may have to resect that segment of the intestine. Radiofrequency ablation, RFA, can be used and is used a great deal nowadays for liver metastases. Cryoablation, freezing tumors, is not used that much, although it used to be a great deal. We can inject various substances into the hepatic artery, that is the blood flow to the tumors in the liver, and treat them in this fashion, and you'll hear more about this from Dr. Sulin. We can replace diseased heart valves. We can relieve fluid that collects in the abdomen by draining it. We can place stents. For example, if there's obstruction of a bile duct, a tube can be inserted into that to relieve the jaundice that may occur. And finally, we can transplant livers, which is not used too often for a variety of reasons, but it's there for special situations. Now, for antiproliferative treatment, which used to go under the name of chemotherapy, we have different types. We have biotherapy, that is, it's not the use of toxic agents that are poisons to cells, but rather biologically active materials, such as octreotide, which is a somatostatin derivative, and also alpha interferon, which also interferes with tumor growth or tumor hormone production. We can do radiotherapy of different types. That is external beam, where a machine is aimed from the outside to irradiate a certain structure. This is not too widely used for a variety of reasons. We can inject substances that go through the whole body, through the bloodstream, and are localized attracted to tumors, and hence give local internal radiation. And we can also inject particles that are laden with radioisotope, and that will go directly to the blood flow, through the blood flow to the tumors in the liver. Again, you'll hear more about that too. And then finally, true chemotherapy of two types. Cytotoxic, that is poisonous material that poisons the tumor cells. It usually has side effects because it's noxious to the normal tissue, but not as bad as to the tumor cells. And then some newer agents that are really molecularly designed to affect certain growth pathways, the enzymes that catalyze growth in tumor cells. And I will mention more about that in a minute. Now, new developments. This, in particular, is hot off the press in some instances. And some of this is not a matter of medicine, but rather a matter in an approach to these diseases. A few years ago, a summit conference was convened by the National Cancer Institute in order to review with all the experts in carcinoid and neuroendocrine tumors, in order to review what was needed in progress for researching, for diagnosing, and for handling this whole group of tumors. And not only that, but how would you evaluate the results of such research? And this finally was published last year, the results of this big meeting. And so we're little by little coming to a national, if not international, recognition of proper ways to go about investigating this whole field. And the fruits of that effort are beginning to show. One of the other things that's come about is a general consensus that since these diseases are so complex and involve so many different things, both in treatment and in research, a multi-specialty team approach is needed. No one doctor knows enough and can handle every single aspect. Requires the radiation expert, requires a chemotherapy doctor, requires a surgeon, requires endocrinologist, a nutritionist, etc., etc. And therefore, a multi-specialty team approach is the best way. Now, that doesn't mean all these doctors have to be in the same house, but at least they have to recognize that they must each have a contribution in the management of the case. And then finally, as a result of all of this, 2 new drugs have just been approved a couple of months ago by the FDA for pancreatic neuroendocrine tumors. Both one drug called everolimus, and also under the trade name of Afinitor, and the other drug, sunitinib, which is known as Sutent, have been approved for pancreatic neuroendocrine tumors. They're both still under study for carcinoid, where they've also shown some benefit, and I suspect they'll eventually be approved for that use too. And these drugs are targeted. They have specific actions on some of the growth pathways, the chemical processes required for the cellular growth. Now, they, interestingly enough, have opposite effects on blood glucose. One of them worsens blood sugars, and so is not good at all for people who have diabetes. It makes it worse. And the other one has the opposite effect. It lowers blood sugar. So some diseases, for example, insulinoma, where blood sugar goes too low, might benefit the best from the one that lowers blood sugar, or that raises blood sugar, and namely everolimus. And the other one might benefit people with glucagonoma, the variety of NET that causes diabetes. Now, SOM 230, which is the chemical name or the research designation for pasireotide, which is the next generation sandostatin, and has been on clinical trials for a number of years, and has some advantages, it looks like, over regular sandostatin, has been reported to control symptoms in over 1/4 of patients who have failed to respond to regular LAR. And more studies are in progress now, but eventually I imagine that drug is going to become available. It may also have some other utilities, which I won't go into at this time since they're only speculative. The PROMID study, the name given to a study for octreotide and lanreotide, as to the ability to inhibit tumor growth as versus the ability to inhibit tumor function, has proven that regardless of whether the tumors are functioning or not, these drugs do have an inhibiting effect on their growth. And so they're useful for that purpose now, and they're getting greater use in non-functioning tumors. These trials are all ongoing. Now, there are many new agents and many combinations that are being studied. For example, it's been shown that there's a longer survival with the combination of lanreotide and alpha interferon. As you're going to hear from Dr. Fine later today, there have been some excellent responses to zalodotemidar combination, and the studies are still going on in that regard, which he'll tell you about. There's been an interesting comparison of TACE, that is transarterial chemoembolus injection into the liver, with combining that or comparing that with yttrium-90 radio microsphere injection, and perhaps we'll hear some comments from Dr. Sulin about that. And then finally, PRRT, peptide receptor radiotherapy. That means injecting into the circulatory system, venous injection, of a radioactive substance attached to a analog or a derivative of sandostatin or of somatostatin, so that it's attracted to tumors. That's what PRRT is, and we're using lutetium-177 and yttrium-90 for that now. It's been shown that it definitely improves survival and is responded to by the majority of cases of any of the neuroendocrine tumors. That means not only carcinoids, but also the pancreatic NETs, perhaps with the exception of insulinomas. In order to be effective, these tumors have to have a positive octreo scan, because the mechanism that made the octreo scan positive is also involved in the attraction for this medicine, and consequently, a patient with negative Octrio scan would not be suitable for PRRT. I might add that this has been studied for well over 10 years in Europe and is only now just starting on clinical trials in the United States. We've had a great resistance here to importing materials from Europe, especially since 9/11. It's been difficult to import a radioactive substance, and consequently, we've been required to manufacture it and to do all the basic studies over again here. And finally, it's just reached the clinical trial stage where there are 2 centers in the country that have started up with this now. And then we have clinical studies of VEGF, vascular endothelial growth factor, and its receptor. And this involves a drug you've heard of, Avastin, which is also bevacizumab, and also Sutent, the newly approved drug, and other types of similar medications. And then there's a very small group of patients with far advanced liver disease who have had their liver isolated with the catheter going into the blood flow into the liver and catheter coming from the blood flow out of the liver. So the liver is isolated from the circulation of the rest of the body, and a potent medication, melphalan, has been injected and circulated through the liver. Very, very powerful toxic material, and it has salvaged a few cases. It's a radical, drastic undertaking, only done in a few centers, but in some cases has been helpful. Then we've also had the introduction of laser interstitial thermotherapy. It's using a laser to destroy tumors. That's very new. And then so new that I don't even have it listed on my slides because it was only presented 2 weeks ago at the annual NANET Symposium, are several other points. The isolation of a substance called activin A alpha, or activin A, which is a tumor-produced material that can be used as a marker for carcinoid heart disease. So now we will have a substance we can test in the blood and say this patient is at risk or has carcinoid heart disease. Then we also have 2 other substances that are produced by pancreatic neuroendocrine tumors specifically. And if they're elevated in the blood, we can say this tumor is a PNET. And this is important because a certain percentage, about 10% of all cases, will present with metastases in the liver, and we don't know where the primary is. So we're not sure exactly what the best treatment may be, but now we have a test, 2 tests that we can do that'll help tell us if this is from the pancreas. And they're called islet-1 and PAX-8. Those are just the names of these substances. For example, the pathologist can stain a piece of tissue from a needle biopsy of the liver and tell you CDX2, that's the name of the stain, was positive, and that helps to tell us that it's from the intestinal tract. That was the origin. Or he can tell us it was TTF1, which means it comes from the lung. Now we can stain for islet-1 and PAX-8 and say if the others are negative and these 2 are positive, he can say with about 85%, 88% assurance it's from the pancreas. And that's a little step forward. And then finally, the last item, there is a clinical trial in progress with a substance that's been named tilotristat, which itiprate. It's really rejuvenation of an old hormone or an enzyme inhibitor that inhibits a substance called tryptophan oxidase, which is the first step in the synthesis of serotonin by the body, and this prevents that from happening, and so has been useful in some patients who have resistant to diarrhea in carcinoid. And I know there are some of you in the audience that have that problem, and the diarrhea is not completely or adequately controlled by octreotide. This new substance has been helpful in that regard, and it's just completing clinical trials. It's not yet approved. Finally, here's a scheme for treatment. Once the diagnosis is made, there may either be no treatment, which we don't follow so much nowadays, but it used to be the wait-and-see regimen was practiced because there wasn't any good treatment. Or we can do surgery, either for a cure or for palliation, or which may be for a variety of reasons I explained before. Or we can do medical treatment, which may help, and maybe convert an inoperable case to being an operable one. And of the medical treatment, as I said before, we may have supportive measures. We may have radiation of different types. We may have biological anti-tumor treatment. We may have chemotherapy of the traditional type with cytotoxic agents, or some of these newer targeted drugs. So we have quite a vista of things that are applicable, but we need to develop the expertise to know what to apply, when, and how. And so in conclusion, we can, at the present time, we can summarize by saying a completely permanent cure is only available at present by total surgical excision of the tumor, including its metastases if they're present. And unfortunately, that's not possible in the majority of cases. Earlier diagnosis is needed. But we can produce palliation and longer survivals by customizing each case and being more aggressive in our surgery and doing multiple types of treatment, one after another in a sequential fashion. And then these newer treatments are very promising. I thank you.
Thank you, Dr. Warner. Owen, thank you so much for that. I always enjoy listening to Dr. Warner. It's just like this wealth of information